We'll start off the webinar, and I just want to thank everybody for joining. I'm Emily Crossley, co-founder and Duchenne UK and mum to Eli with Duchenne. We're bringing you this webinar at an unprecedented time in all of our lives, a time described by the Prime Minister as a moment of national emergency. All of you will be feeling not only the anxiety felt by everyone else, but as parents and relatives of children and adults with DMD, we will of course have a heightened sense of fear at what COVID-19 means for our community.
Hello everyone, I'm Alex Johnson, co-founder of Duchenne UK and mum to Jack. I've been speaking to as many of you as I can in the past week to try and help you with your concerns. However, I'm not a doctor, and our charity is very clear that we should never be giving medical advice. However, we want to be here to help and support our community by giving you as much information as we can.
We have been updating everyone on the government guidelines, but these can sometimes create more questions than they answer. So we're really pleased today to be joined by Professor Francesco Muntoni, neurologist from Grosvenor Street Hospital and University College London. Thank you so much for joining us, Francesco. We're going to dive in with our first question, which is about steroids. Oh, hold on. There we are, which is about steroids. And trying to clarify the government message on these, because according to government advice, patients are at risk if they're on immunosuppression therapies sufficient to significantly increase risk of infection. Are corticosteroids, deflazacort and prednisone, at the dose they're given in Duchenne, considered to be immune suppressing?
Can you hear me?
Yes, we can hear you.
Good. So I think that now I'm going to give an answer that may be satisfactory up to a point. And I think you need to understand that nothing is black and white. We would all prefer to have things that are black and white. Now, if you want to give a patient an immunosuppressive dose for a particular reason, you will use higher dose than the one we use in the patient treated chronically with corticosteroid in Duchenne. Having said that, the patient with Duchenne probably are the only patient who are treated with this moderately high dose, not a full immunosuppressive dose, but moderately high dose for many years. And there is very little information regarding what is the level of immunosuppression that this chronic treatment may give. I think you can look at it from the perspective that there has been really in the last 20 years, no report of children with Duchenne who have experienced the problem related to severe immunosuppression and superimposed disease as a result of the chronic corticosteroid. So that risk of severe or significant immunosuppression must be very small. If you ask, however, can you absolutely exclude the possibility that some patient may be immunosuppressed to some extent? The answer is probably we do not know. That's also why we recommend not to do live vaccination for flu, and that is why people with corticosteroid receive the varicella zoster immunization before starting. We just don't want to find out whether there is a significant immunosuppression. In absence of clarity, however, a consensus of the neuromuscular doctors, not only at GOSH, but nationally, is that people with Duchenne muscular dystrophy, not just because of the steroids, but also because of the other comorbidities, should be considered patients at high risk.
Okay, so the next question, should patients stop taking steroids? I'm assuming the answer is no.
I think that is, of the many things that will be wrong, that is the one that will certainly cause a lot of trouble. I think that the steroids cannot be stopped abruptly anyway, even if people want to stop them. And as you are aware, there are potential significant adverse events by stopping them. If anything, and this may be one of your next question, if people are not very well or as a result of this infection or other infection, if anything, they may require more steroid, not less steroid for a period of time.
Yeah, we'll get on to that. But just before, one question that came in was that if a child with DMD is still ambulant, active, and with no additional complications, does having Duchenne mean they are at greater risk of COVID-19, or is it the taking of the steroids that could theoretically put them at more risk?
I don't think that we have a particular knowledge that to give them the steroid at the dose that are given, put them at a particular high risk. And we also, you probably are aware that there are ongoing clinical trials using moderate dose of corticosteroid in COVID-19. So there may even be a reason why the corticosteroid could be theoretically helpful. However, firstly, we don't know. Secondly, people with Duchenne have other comorbidities. Of course, the younger the child, the least this will be. But of course, you're aware there is heart involvement in Duchenne. There may be muscle. There is for sure skeletal muscle involvement, and there are other reasons to. And in the later stage, there will be respiratory involvement. So there are other reasons to shield this patient from the COVID-19.
Thank you, Francesco. You used the word comorbidities. For the layperson, you mean by that potential heart complications? What else could be a comorbidity?
Yeah, no, that's what I meant. I think is really the fact that they are. I think that is actually probably three would be the most immediate one. So the first one is the fact that there is a higher risk of heart involvement, and COVID-19 appears to potentially be a bigger problem for people who have an existing cardiac problem. Of course, this will be, I'm talking about adults with more advanced cardiomyopathy. I'm not talking for the younger population of people with Duchenne, but of course, there are also the young adults with Duchenne in whom cardiomyopathy is present. So these will be people in whom there clearly is a higher risk than the general population. The second relates to, at the later stage of the disease, the respiratory complication, the respiratory weakness will be the comorbidity. The third, and in this way, you could consider the steroids carefully, is the fact that this is not specific for the COVID-19, but being on chronic corticosteroids means that irrespective of this particular infection, it could be a post-trauma, people breaking a leg. There is a not full ability to mount the stress response from the adrenal gland. So to be on chronic corticosteroid predispose people with Duchenne to potentially have more severe consequences as a result of fracture, big falls, and infection. So from that perspective, the corticosteroid put the children in one particular risk category in case they were going to get the COVID-19.
Okay, well, that very helpfully leads us on to our next question, because you mentioned earlier that, if children on steroids are not well, they may have to increase their dose. Can you explain, I think this is known as stress dosing, so can you explain what stress dosing is and when should it be used?
Well, so one thing that it happens in all of us when we are unwell is that our adrenal gland pumps more steroids up to improve the response to an acute stress. This can be a surgical stress, it could be a fracture, could be severe pain, could be an infection. So the paradox in people with Duchenne is that because we give the corticosteroid on a daily basis, they are getting clearly much higher level of steroids than what my body produces on a daily basis. However, because we're giving the corticosteroid every day, we are resetting the system to allow them to produce higher level if a stress is presented to them. So paradoxically, if I break a leg, I can produce level of corticosteroid that are much higher than one that a child with Duchenne is taking on a daily basis, while the child with Duchenne will not be able to increase the level that they produce. So I think this is a well-known role that corticosteroids have in producing a response to a number of different stresses, and this is abolished in people with Duchenne.
Thank you, Francesco. So we're going on to the next slide, and this does follow on from stress dosing, because some patients have been given hydrocortisone packs. I'm just going to bring up the slide now. Some neuromuscular clinics have advised patients to get a hydrocortisone injection pack. Can you just briefly explain what they are, and should all of us have one?
So firstly, I think the most important information is to be aware of what we just said, and I think that the emergency hydrocortisone pack is, if you like, a more advanced step of some steps that may be earlier, and they can be, and they've been discussed in both with the advocacy group and by the physician in the UK. That is that of just increasing, if people are not very well, but they are not critically unwell, because as you realize, there is a scale of things from being a little unwell, moderately unwell, and critically unwell. So there is, the majority of the children will not be critically unwell. And therefore, there may be, or there have been a recommendation in terms of how to deal with just children who are not completely well, but they are not as unwell to require, if you like, the full spectrum of measures. I think that the advice from the various endocrinology teams, I think that have been consensus statement from the UK and European endocrinology team as late as late 2019. And for example, at the Thomas Hospital, where we work, the final guidelines has been circulated at the very end of 2019 in terms of what the if you like, what could be optimal way to deal with mild problem, moderate problem, and more severe problems. I think that the hydrocortisone emergency pack should be discussed with your local doctors. Not necessarily, if your local doctors have not explained this to you, is because they are not competent. This is this new regulation came into force, or could have been recommended as from December 2019. So we have, for example, started to discuss what are the best way to reach out to as many families as we can in the short period of time. But I stress, this is an important step, but it is for children who are quite unwell. The great majority of children will not require this level of support. There are guidelines that have been circulated. We have our own Greater Ormond Street Hospital guidelines that are probably not very dissimilar from that of other centers. So it will be probably useful for families to know what are the guidelines and what to do in the various spectrum of problems, which this is one, is not the only one.
Okay, thank you, Francesco. So the best way for patients to access one of these emergency packs is to contact their neuromuscular clinic, who can write a prescription for their GP to then prescribe.
I think that there will be, yes, I think that, and also I think that the reason why this is takes a little time, there needs to be some training that families need to have, and so on and so forth. So that, I think, is what we are currently, at least at our hospital, implementing, and we have planned. You know, of course, this COVID-19 has come in the way of the timing of what we had planned, but my clinical colleague had together with our endocrinologist and our specialist nurse. I'm speaking for our hospital. Other hospitals maybe are ahead of us, maybe as we are, I do not know. But I think that there is a training required as well. And for example, in our smaller clinical trial facility, our specialist nurse have been able to give the information regarding the new guidelines to our patient, but we haven't been able to do it systematically for all patients coming to all the neuromuscular clinic as yet, although this will happen.
Okay, thank you. And just one question related to this area. So one of the symptoms of COVID-19 is a high temperature. Should we ever increase steroids for a temperature?
I think that so I think you should do what you were doing in other situation, and I think that the most important thing is if you will know if your child is unwell, and to some extent the temperature is one of the many aspects of the children being unwell. But if the child looks well and he's got mild temperature, probably I would not be particularly bothered. At the same time, very often the child will be have some temperature, not being very well, and then yes, I think I would increase the corticosteroid in these children. I think that what it becomes, and there are some suggestions on how to do this. By, for example, doubling the dose for a few days, and you would have received this information. I think where it becomes more critical is if the children are not able to keep things down because they're either vomiting or they have diarrhea. That, I think, is where you really people need to feel that they need to scale up their if you like, the way they're dealing with it. Again, please use your common sense. If your child has, vomits on one particular occasion, 3 hours after lunch or whatever, and then he's well, nothing important would have happened, but it's really the repeated vomiting and the inability to keep things down, or diarrhea that with accelerated transit in the gut. And in that case, the absorption of the steroid may not be ideal.
Okay, thank you, Francesco. That was very useful. And I suppose just to reiterate what you said to families listening, that when you do speak to your neuromuscular clinics about these emergency packs, they will give you information on when you may need to use it. So don't feel alarmed that you're not fully across when you might need to use it. Your neuromuscular clinic will give you all the information that you need. Okay, so we're going to the next question.
So there are, for example, there are, in the leaflets that you will receive from our endocrinology team, there are all the information regarding what is that makes you should make you concerned about your child. That probably will make you concerned anyway. That will be a child who is very pale, a child who is sweating a lot, a child who appears to be not very well coordinated, and those are not, however, the typical things will happen to children when they are a little unwell. But I think those are the things that will be important to recognize as unusual. And I think you, as family, know your children very well. Something unusual, you should worry.
Okay, so that does lead us on to what to do in an emergency. So if a Duchenne patient has symptoms of COVID-19, fever, cough, and shortness of breath, what should they do? Should they follow the general advice to everybody?
Yeah, I think that, so there is, the good news is that, if you like, although people have Duchenne, and I think here probably we need to discuss about divide children from adults with Duchenne. I think that to have Duchenne only is not a sufficient identifier, if you like, of this question. But if you are, I make an example, if you are ambulant with Duchenne, so you are 12 or whatever, and you are on the whole, you're well, the respiratory function of a child of 12 who is on corticosteroid will be essentially 100%, 80% of predicted values, okay? So this is within the normal limit. So the good news is that children, for a variety of reasons, appear to tolerate COVID-19 much, much better than adults. And I have initiated a questionnaire in all the European countries to know, for both Duchenne and other neuromuscular disorder, where there are particular problems of children who had to be admitted with COVID-19. And it's very reassuring that things appear to not behave in any different way from that of other children. And in other children, things are very good. So there is no specific reason, therefore, to think that a particular child will be much different from having got an ordinary flu. At the same time, of course, you will know your child, and if your child looks that is much less well and is struggling with with whatever is happening, then I think it is the time that you need to contact the guide to use the guidelines that the government has put in place. I think that in terms of should they take oxygen, well, oxygen will not be available at home, but it may be available in hospital. I think that the message for any neuromuscular patient is it's not that oxygen is a poison, but especially in patients who are more advanced in the disease and in whom there may be what we call hypoventilation, poor breathing capacity. Oxygen can be given, but I think it's important to measure also other gases in the blood, like the carbon dioxide. So it's not that oxygen cannot be given, but in the more advanced stage of the disease, oxygen can be given, but also monitor the blood, other blood gases. So I don't think one should be particularly concerned that oxygen should not be used. It's just use it, but get other things checked as well.
Thank you very much, Francesco. And it's very reassuring to hear that you're trying to gather data from your European colleagues. So do you mind me asking, from the questionnaire that you sent round, does that mean then that boys or adults have contracted COVID-19 and seem to have had mild symptoms? Or maybe
well, I think that no. Well, I don't have the full answer to your question as yet. I'm aware of one child. This is in UK with severe spinal muscular atrophy, type 1 SMA. These are children who are, you probably are aware these are children who are never able to even sit unsupported, and this particular child is on ventilated at night. This particular child sailed through COVID-19 very well, probably better than the parents. I think that we are aware that that has been some older individuals in Italy with I cannot guarantee which neuromuscular condition was, to be entirely honest. And again, these people did not have any particular problem. And I suppose what it is important is to consider that even the mortality in China, there has been a single child among all the individuals in China who died because of COVID virus. So the risk, and of course, children will be much more exposed to this. You cannot shield children very easily. And at school, as you can imagine, probably 90% of the children in a classroom will easily become or especially in China at the time that the outbreak was up and running, would become infected. So that risk is therefore defined by the age more than anything else. And in children, this risk is very small. It may be different in a more advanced stage of an individual with Duchenne who may be in the 20, 30, or 40s. That I think certainly one will be much more guarded, and all the possibility or the efforts to avoid exposure in this patient become much more important.
Thank you, Francesco. And on the slide, I just want to draw people's attention to the link to the Duchenne A&E website, which is a useful resource if you do have an emergency. Okay, we're doing well for time, but perhaps we could move on now. And I know you addressed this at the World Duchenne Organization's webinar, but there was concern about the potential of ACE inhibitors, heart medication like lisinopril or perindopril, to make people more susceptible to the virus. what's your advice on this? Many patients take these medicines. What should they do?
Well, I am a pediatric neurologist, so I follow the advice of the cardiologists. So the several national societies of cardiologists have issued their recommendation indicating that there is no reason, with our understanding at the moment, of why patients should stop this cardiac medication. And I think some of these came from the observation that there is a higher, if you like, morbidity and more severe disease in patients who had pre-existing cardiomyopathy. And the question then is this because these people are taking a medication, or is this because they have a cardiomyopathy? I think that at the moment, the advice is that the ACE inhibitors are unlikely to be a contributory factor for their condition. You have to appreciate advice may change if evidence changes, but that is the best advice from the professional bodies at this point in time. And you can look at it from the other angle as well, that if it is true that the that the condition may be more severe in people with heart condition, and this wasn't related to the medication, probably the last thing you want to do is to stop a heart medication at the time it may be even more needed. So as of 25th of March, there is a complete consensus from all not just in this country, but also in other countries, the professional bodies, please do not stop the heart medication. It may even be a bad idea.
Thank you for clarifying that. Okay, so the next set of questions is about what to do in terms of hospital appointments. Some of this has probably been a bit superseded by government advice now, but the first question was, should we be attending hospital for current appointments? Clearly that's not going to happen now. And most hospitals, I think, have now gone on to sort of remote appointments. But questions have been asked about what treatments would be okay to postpone. So, for instance, bisphosphonate infusions or testosterone injections. Do you have any thoughts on whether it's okay to postpone those?
Well, I think that all our brains need to work in a risk-benefit mode, in addition to the practicality mode. So, I suppose if I make an example now. So if my child had a scheduled 6-month appointment for biphosphonate, but my child is well, I would talk to my endocrinology colleagues or to the endocrinology colleague and say, is it sensible to postpone it by 2 months, for example, so that I come to a hospital at the time when hospitals are more able to cope. And in addition, I also reduce the risk of infection, because the hospital is unfortunately one of the places where you will find more of this COVID-19 up and running. I think it would be different if the child has pain and requires something to be done, because we know that in that case, firstly, the biphosphonate help the pain. Secondly, the pain per se can give rise to, we were talking before about the adrenal axis, and if the child is in severe pain, I think that is undesirable for people with Duchenne. So risk-benefit would need to be, it's a bit difficult to give therefore a general answer that will satisfy everybody. I would encourage people to consider if this can be delayed without any obvious consequences for a few months. Probably this is the time to pick up the phone and say, we'll come in July.
Okay, thank you. We're going to move on because we are, time is marching on. We talked about how you shouldn't stop taking steroids and that the current advice is to not stop taking heart medication. But are you aware of any medications or any trials of medications that may increase vulnerability to the effects, or the effects of COVID-19?
Well, I think that paradoxically, low dose of steroid are being now tried, and we should hear in a few, probably weeks' time, effect of these. We know that high dose of corticosteroid will probably not be a good idea. Very high dose, full immunosuppressive dose, and other immunosuppressant. But these are not drugs that will be taken by people with Duchenne. I think that I suppose there will come the discussion of this is different from probably your particular question, but I suppose the question is, would this be an ideal time to recruit a child in a AAV gene therapy trial? And apart from the practicalities, but also if people get both AAV gene therapy trial and the COVID virus more or less at the same time, that will probably be highly undesirable. So I think that there will be this additional complication, and that there will be not only for Duchenne but also for other neuromuscular conditions. So that I think is an important consideration perhaps to have. I think in terms of the ibuprofen, I think the general advice for people with Duchenne is and people on corticosteroid is to avoid drugs such as ibuprofen or other drugs of non-steroid anti-inflammatory drugs, mostly because of the stomach and ulcer risk that this drug put. In children, we strongly recommend to use paracetamol. Is much better tolerated. The risk profile is very well known. It doesn't add up in terms of side effect to the corticosteroid, especially for the stomach. So I think that it looks a no-brainer to use paracetamol and not other drugs, but not only for COVID-19, but in general.
Thank you. We asked a question about is the hub or our clinical trial centres making plans for the continuation of trials, treatments, provision of drugs? I'm conscious of time, and I'm wondering whether we might leave that for another day, because I feel like that's a huge subject area, the area of the impact of COVID-19 on clinical trials. Or is there something you could briefly say now about patients who are currently on trials?
Well, I think that we are every week is a different week. I think at the moment there have been, if like everything that can be done remotely or at home. For example, some of the antisense oligonucleotide with home dosing. We have asked the sponsor to increase the frequency of the home dosing, and this has been agreed in most of the clinical trials. So, for example, we do not expect now to see some of the children for at least 3 months, for example, and that I think is to have access to the drug closer to home. For drugs that can be shipped, we are in discussion with the pharmacy and the sponsor to ship by courier the drugs at home. And we are in discussion with the various sponsors to identify optimal ways to capture some of the potential efficacy and milestones in a way that could be still acceptable. So I think that there is, is a variable situation depending on the clinical trial. So at the moment, we still have a patient who comes to hospital for individual clinical trials, but we ensure this patient, if they come, they do not come by public transport. They do not take, they cannot take a plane, they cannot take a train. If feasible, in terms of distance, we will arrange a taxi for them. But I think we also need to be prepared that there may be emergency closure of the clinical research facility and or shortage of nurses and doctors redeployed to do other things. So I think this will not be forever. It will be for hopefully a very limited period of time.
Thank you, Francesco. We've only got 2 more slides now. So the next one is really more of a question about how people should self-isolate. So the NHS text that many of us received stated that we shouldn't go outside for 12 weeks. And it implies that you shouldn't even go into the garden, because they say you can open a window but do not go outside. So we've had this question from quite a few parents. Is there a medical reason that we shouldn't go into the garden? And if say they live in the countryside and they can go for a walk without seeing anybody, can they do that?
So I think that I suppose a brief text from the government cannot encompass every single situation, and probably to be on the safe side and assuming some people may not have a garden, I think this was an advice of what would be safe. I think if people have the ability to be to have a garden, there is no reason why you're not allowed to go into the garden. In actual fact, there are guidelines. Even if you were affected, you can still go to your garden, but there are distances you need to respect from. I think you need to be 2 meters or 2.5 meters from the perimeter of your garden. So even affected people can go out in the garden. So there is no reason why your children cannot go in the garden. I think in terms of the, in answer to the second question, in whether people can go outside, well, I think the government guidelines there is to avoid unnecessary trips. So I would think that is probably one that will be considered to be unnecessary, or not necessary now, not strictly necessary now, because you could always have a situation where you meet people you didn't want to meet, or a group of people, and I think that is an unavoidable risk.
Thank you for clarifying that. Okay, so the last two questions are, COVID-19 is in the same family as SARS and MERS. Is there any data relating to DMD patients and MERS, SARS from the last epidemics? And what treatments were used? What, if any, effects did we see?
Well, I think that the difference with the MERS and SARS, they were very, very limited. They were so I'm not aware of any child with neuromuscular condition was exposed, but the number of people affected were really different order of magnitude. So it may well be that none of these individuals with neuromuscular condition became affected. To be entirely honest, however, I cannot confirm. I'm just using my analogy. I haven't heard about patients with neuromuscular disorder affected by those conditions. And I think we discussed before about the second point, that is of the immunosuppressed children, people who are significantly immunosuppressed. Yes, there will be potentially issues. There are some guidelines that have been issued, not necessarily in neuromuscular patients, because really a minority of patients will be significantly immunosuppressed by people with other conditions, or even adults with, multiple sclerosis and rheumatoid arthritis, who may be under severe or significant immunosuppression. These people are potentially more at risk. But I think, again, it doesn't apply to people on corticosteroid of the regular dose that families get and children get in Duchenne for corticosteroid.
Thank you. And we know that COVID-19 tends to affect children less severely if they have a normal immune system. And we have discussed this a lot on this webinar, but has there been any information about children and teenagers, for instance, on chemotherapy or other immune deficiencies in this sort of scenario?
I think we are in the theoretical scenario where you could be I really like to avoid. There are well-demonstrated risks of dissemination of viral infection in patients who may be severely immunosuppressed, but you do need to appreciate, and I'm sure that everybody appreciates, the information we are getting at the moment is still evolving, and the detail of the information is still so little. We very often been told that some people have passed away, usually older people, in whom there is comorbidities, but the information, what are these comorbidities or additional conditions these people have, they are not shared. I think this may change with, there have been publications, even for COVID-19, to indicate in adults what are the conditions that these people had before, because people with Duchenne, people with children do not appear to get this condition in any significant way. There are no publications on significant consequence in children. There is a single publication on description of maybe 20 or 30 children who got it in China, but these were children without a neuromuscular disorder. They did all very well. and it just reports what were the frequent, how many children got diarrhea, how many children got this and that and that. But I think that if you consider the relatively rarity of children on severe immunosuppression, but also the already these are people who normally would be already pretty isolated, for whom also other viruses pose risk. So these are particularly a group of people who are really particularly shielded. So the probability some of these individuals will get COVID is really, really small, and hopefully we will never find out what happened to them.
Well, Francesco, that was really, really helpful. And I just want to thank you so much for giving us your time. I know what must be very, very difficult and stressful. And I'm sure I speak on behalf of everyone when I say thank you to you for everything you do for our community. And we really hope that you stay safe and good luck in the coming weeks. So thank you very much indeed for joining us.
Many thanks. Have a good evening. Thank you.
Okay, you too. So we're just going to finish off now with a slide that we thought would be helpful to share with people with some useful resources on it. So the emergency website that I mentioned before, the family guide, which details everything you need to know at every stage of the disease, the government website for updates on coronavirus, and the NHS website. The My Cortisol app is very useful for advice on using your hydrocortisone pack, and the World Duchenne Organization's website is providing updates on COVID. So if you have any questions that have arisen from today or any new questions, then do please get in touch at support@DUCHENNEUK.org. I know we didn't cover all the issues today, but we are planning a number of webinars in the coming weeks. And so if there's any specific topics you would like us to cover, then do let us know. So thank you so much for listening. Please do stay safe and stick to the government advice. Remember, this is a moment of national emergency. Stay at home, protect our NHS, and save lives. Thank you very much, everybody, and goodbye.